We are going to discuss endocarditis. Here are our objectives related to endocarditis. Endocarditis is inflammation of the inner lining of the heart or the endocardium. This can affect the heart chambers and more commonly the heart valves. And endocarditis may be non-infectious in nature or it can be caused by infection, primarily bacteria. Non-infectious endocarditis, what's going on is you have inflammation to that endocardium, right? And because of this, what is our body going to do? It is going to try to repair that endothelial damage caused by the inflammation. So we're going to release platelets, we are going to release fibrin, fibrinogen, and other factors to repair that damage. And this can lead to a thrombus formation on our heart valve. With infective endocarditis, the same thing is happening, except in this situation, we have some type of infectious organism circulating through the blood. And remember, platelets are very, very sticky, right? So, in infective endocarditis, what can happen is the patient has that thrombus formation, but now, as the infectious agent is traveling through that heart valve, it can now be stuck onto that thrombus. And infective endocarditis is going to be much more common than your non-infective. Now, the pathophysiology for infectious endocarditis is the same of that for non-infectious endocarditis, except somehow a pathogen, usually a bacteria, sometimes a fungus, has gained access to the body and is now circulating in the bloodstream. Now remember, endocarditis occurs when damage occurs in the endothelium. And now you have those platelets, fibrin, fibrinogen that all come to repair that damage. And this is very sticky. And now you have this infectious agent circulating through the bloodstream that has to pass through that sticky mesh that is formed. And it is prone to adhering to that. And now you have a septic thrombus. You may hear it called a septic emboli if it dislodges, or you may hear it called a vegetation. Now, what are the risk factors of infectious endocarditis? Well, having non-infectious endocarditis, all you need now, if you have that inflammation, is for an infectious agent to have access to that bloodstream. Now, having any type of oral or dental surgery can actually place you at risk. We're finding out more now that your mouth actually has like a direct blood flow to your coronary system. And we know our mouth is a very dirty place. So you will see this usually 3 to 6 months after an oral surgery. Now, those who have had any type of cardiothoracic surgery, if they have devices placed such as an ICD, a pacemaker, central lines, PIVs can even lead to endocarditis depending on the frequency, how well a septic technique was adhered to, other risk factors, immunosuppression, HIV, having any type of congenital heart defect, prosthetic valves. Remember, we're introducing something new into the body. Having valvular defects such as aortic stenosis, severe mitral valve prolapse can place you at risk. There are various risk factors, but a lot of times questions are going to be focused around the prosthetic valve, oral surgery, and IV drug use. endocarditis, you're going to see some pretty non-specific signs of infection, such as your fever, your chills, your malaise, your headache, your anorexia, because you have an infection. And now, especially with acute endocarditis, this can elicit quite a significant immune response. So you may see splenomegaly. Remember, your spleen is your white blood cell graveyard. So you've developed all these white blood cells to try to fight this infection, and now they are dying off when they've done their job. You may also see some clubbing of the fingernails, some generalized cyanosis, because ultimately this can decrease your perfusion. You can also show signs of vasculitis, such as petechiae or splinter hemorrhages. You can see them in your nails. And what's going on is you have this septic emboli that have, like, little pieces of it have broken off, and now they're getting stuck in your microvessels. You may also see some conjunctival hemorrhages, and you can also see Osler's nodes, which are going to be painful, tender, red, or purple-sized lesions, and Janeway's lesions, which are going to be your flat, painless, small red spots. And these are going to occur because of the immune response that has been elicited from the endocarditis. And you may show signs of embolization, whether it's a microembolization or a significant emboli can occur, and I'll get there.
Diagnosing endocarditis is going to involve an extensive health history, especially in the recent few months. Have you had any new dental, urological, surgical, or gynecological procedures? Because these invasive procedures can lead to endocarditis. You want to see if they have a history of heart disease, a history of valvular disease, any congenital abnormalities. Have they had a history of rheumatic fever? Do they have any type of prosthetic material, such as a pacemaker or a defibrillator placed? Do they have an artificial heart valve? Does the patient have a recent history of a central line being placed, whether it's for medication administration, dialysis? Is the patient an IV drug user? You want to do a drug test. You are going to do a series of blood cultures to determine if it's infective endocarditis. You are going to do your nonspecific inflammatory markers such as your ESR and your CRP. You're going to do an echocardiogram, and preferably you're going to do a TEE. And this is an invasive echocardiogram where the camera is going to be placed in the mouth, down the esophagus, and this will give you a better visualization of the heart valves and possible septic thrombus on any of your heart valves. And this is going to be much more detailed than your non-invasive echocardiogram. You may see EKGs performed. Heart catheterization may also be performed. Endocarditis can lead to multi-system effects, and complications of endocarditis may be very mild or they can be life-threatening. Certain complications are going to involve embolization. So we have a thrombus on our heart valve and it can dislodge. It can go to the spleen, lung, kidney, liver, the lungs. It can go to the heart and it can go to the brain, causing an embolic stroke and infarction. Yes, your spleen can become infarcted. Yes, you can have a kidney infarction. You just don't see that often without that embolization. And a patient may have developed meningitis, an intracranial hemorrhage or abscess. They may develop heart failure, valvular dysfunction, arrhythmias, myocardial infarction. You may see an acute kidney injury developed. Treatment for endocarditis is going to be aimed at treating the underlying cause, supporting the body, and preventing any complications. And you're going to see that endocarditis treatment is going to be a multidisciplinary approach. And it's going to involve various disciplines, both inpatient and once the patient is discharged. You may see infectious disease is going to be involved to ensure that the patient is taking the appropriate antibiotics for that causative agent of that infective endocarditis. They're going to determine if the antibiotic treatment is working. And they're going to follow up outpatient as well because these patients are going to be on long-term antibiotics. You may see cardiac surgery may be consulted, and they're going to review the cardiac imaging. They're going to determine if the patient is a surgical candidate, and they're going to perform any type of heart valve repair or replacement that may occur. And often the patients will follow up with them following surgery to ensure that they are adhering to the post-operative plan, such as anticoagulation, and if they're avoiding things that place them at high risk, cardiology is going to be consulted. They're going to review that initial echocardiogram. They're going to recommend further imaging. They're going to see if there's any septic emboli on the heart valves, and they're going to give their input. You can also see that addiction medicine may be involved, or social work, because remember, a lot of endocarditis is going to be caused by lifestyle choices such as IV drug use. We may need social work or coordination of care to follow up with home care for the patient. You may see neurology could be consulted if a patient has a septic emboli. They had a thrombus on their, for example, mitral valve, and it broke off and caused an embolotic stroke. And they're going to be involved to support that stroke and give any recommendations on preventing further stroke. And as the nurse, we play such an important role in patient education, and nursing tests like to focus on patient education. So it's important to emphasize the importance of maintaining therapeutic levels, teaching the patient to take their antibiotics as prescribed, and these patients are going to go home on long-term antibiotics. It's important to teach them to care for that infusion site, to maintain aseptic technique, because you don't want to increase that risk of that bacteremia caused by that central line. You want to teach them about proper oral hygiene. You want to teach them not to vigorously brush or floss or use irrigation systems. You want to teach them to brush twice a day and to make sure that they are practicing good oral hygiene. And you want to always encourage drug abstinence and give the patient resources for any type of drug program. And it's important to educate the patients that they must remind their health care providers, especially their dentists, if they have a history of endocarditis, or even if they have a history of risk factors for endocarditis, such as the rheumatic fever, and they're going to be on prophylactic antibiotics before that dental procedure to decrease that risk of endocarditis coming back. And you will see that those antibiotic guidelines for prophylaxis have been revised over time, but anyone who has had infective endocarditis or unrepaired cyanotic congenital heart disease, you definitely want to make sure that they inform their dentist. And also, these patients are going to be going home on anticoagulant therapy often. So it's important to teach the patient to take their anticoagulants appropriate. They need to tell their dentist they're on anticoagulants, you know. You need to teach them about bleeding risk and things of that sort. And this is the end of the presentation. Thank you for listening.